TopMedTalk.
Nick Margerrison here. Welcome to TopMedTalk. And on today's TopMedTalk, we're going to be having a look into the future. Yep, that's right. We're going to be looking at the predictions that our guests and contributors over the last month or so have been making as regards 2020. What is their 2020 vision? We have some old favourites on here, some regulars, and some very eminent speakers as well, all telling you what to expect in the oncoming year. Let's begin by listening to our first contributor on this piece. It's Gezz Van Zwanenberg, nurse and project lead at North West London Critical Care Network. Gezz tells us his thoughts as to what we should expect.
Where do you want to go?
So I'd like to break it down. So from the patient's perspective in critical care, I'd like 3 R's. So re-enablement, rehabilitation and readmission. Okay. We're seeing some data that shows that critically ill patients discharged are readmitted back to hospital. Yes. A high proportion of them, 50%, something like that, inside the first year.
Yes.
So to a hospital, any patient that's been in critical care is admitted to a hospital somewhere else, not necessarily the same one. And I'm not sure we know why.
Yes.
That would be interesting. The re-enablement and rehabilitation is an ongoing topic for those critically ill patients. We know all the problems of critical care, and we haven't cracked yet how to support them better closer to home. The challenge of a clinician in intensive care is when the patient comes back to a follow-up clinic and says, I've got problems with my local authority, my toilet and my money. They don't know, and they go to their GP and say, I've got a problem with sexual dysfunction, psychotic thoughts and scarring. They don't know, so there's a gap there for those patients. And workforce, and I'd like to break that down into training, competence and resilience stroke burnout.
Burnout from the staff burnout?
Yeah, so from the workforce perspective.
That's a big subject. We've done quite a few interviews about burnout. I found myself sitting through them myself, and Sol and Desiree did some at the Society of Cardiothoracic Anaesthetology last year. I found myself sitting there thinking, I think I might have been burnt out at one stage of recognising these traits they're talking about. So I think we should all learn about it, and we should all be prepared to say, I think it might be happening to me. It's definitely happening to you. And I think we talk about that.
That's a key difference.
I'm pointing at you, Marcus.
Thanks, Monty.
We're role playing here. Yeah, if you have a burnout, we've all got no hope. Mr. Ever Buoyant.
So I think that's another key difference for me as a team leader, as a senior nurse. My military role was specifically to look after the team.
Here.
And I'm not sure that in the NHS we look after each other. The buddy system isn't there. The team leadership role, unless you've known each other for years, and that isn't necessarily as visible, and we could raise that up the agenda, I think.
Here.
Up next, we have 3 different contributors for you. We're going to be starting with Simon Davies, a consultant anaesthetist at York Teaching Hospital NHS Foundation Trust. Then we're going to be moving on to the familiar voice of Mike Grocott, Professor of Anaesthesia and Critical Care at the University of Southampton, and a regular TopMedTalk contributor. And then we'll be moving to Sol Aronson, Tenured Professor at Duke University and Executive Vice Chairman in the Department of Anesthesiology. Let's have a listen.
Right, we're going to dive into some predictions for 2020. We're going to try and avoid politics from that perspective. Okay, yes. We've avoided it. I didn't even say the P word.
No, you did.
I'm not going to say the B word.
No, you are not.
What's the B word?
No,
I'm not going to say the
Can you just mouth it?
No.
Yeah.
Oh, okay. Yes, don't mention that.
Because we're not going to say anything else about in the rest of the world.
The rest of the world.
Except our hearts go out to you, Australia.
Yeah, and other places too.
Yes.
But moving on, so some predictions. So I'm going to dive straight in with prehabilitation. Last year on TopMedTalk, there was a number of different things recorded about prehab. At one stage, there was a prediction that prehabilitation would be the word of the year 2020. And mixed in with that was the suggestion that once you start typing prehabilitation into something that does autocorrect, that it doesn't autocorrect anymore. Now, my technology has stopped autocorrecting. Is that because the world has changed, or is it because...
You type it so much.
I type it so much the machine learns from me. Help here, Desiree. Which is it?
I'm in the same boat, actually, so I don't know. Is it in the dictionary?
I don't know. We haven't checked.
No, you're subject to machine learning, Monty.
Okay.
I think you just type it so much. It must be that.
Right.
So when I misspell certain things, it learns that as well, does it? Okay, never mind. So Simon, prehab. I know you're a sort of believer, but you're also not completely convinced.
I don't know what it is. And I think because it's now become synonymous to me with exercising people prior to surgery. I think that's what the term has become, or it means to a lot of people now. But that's not really the whole ethos of what prehab is. It's so much more. The whole exercising prior to surgery, I kind of think it's a good idea. I remain to be convinced it's beneficial. Sounds good. I'd like to see the evidence. There are so many more simple things we can do beforehand, though. We can look at chronic diseases. We can treat diabetes better. We can fix anemia. Smoking cessation, alcohol reduction, all these little things. If that's prehab,
isn't that all prehab as well?
That's what that's my definition of prehabilitation. When I talk to people about we need to start prehabbing our patients, those are the things I talk about.
If I ask my colleagues what's prehab, they'll say exercising patients. That's
Do you think there's a bias because of CPET?
I don't know. Well, the images that are associated with it tend to be people running on treadmills. If you look at the sort of press releases, the bit that attracts attention is the idea that if you prescribe exercise, so you go get the Lycra on and go to the gym, and you prescribe that everything's going to get better.
I like the Manchester approach. I like the fit for surgery concept.
There we go.
Yeah,
I think that's a lot more holistic and a lot more encompassing in terms of what we're trying to achieve.
So that prehabilitation there, by my take and the conferences, I mean, the World Congress, the third World Congress was in London last year in partnership with EBPOM of prehabilitation. There was talk about fitness in there.
Yeah.
But most of it was those other things you talked about, Simon, it seemed. It was anemia, smoking cessation, habit modification, blah, 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 blah. So I thought it was all of it.
And I thought it was part of it.
Oh, okay,
and therefore, there's a problem, isn't there?
Yeah,
we need to get that message out of really what prehabilitation is. It's not just about getting on an exercise bike. It's not just about fixing your diet. It's a holistic, all-encompassing approach.
It's about being fit for surgery.
Yeah, absolutely.
But you'd accept the fact that trying to get a little bit fitter, which might involve a bit more walking before surgery, I think you're saying it's yet to be clear that going to the gym and being beasted.
I am unconvinced that exercise before surgery improves your outcome. But I tell my patients, go for a brisk walk, do some more exercise, get your heart rate up, get a bit more puffed out. Don't overdo it too much. I inherently think it is a good thing.
Do you think it's one of the sexy topics of the year if we accept the fact that that's a known unknown?
I think it will be. I think proving that is beneficial and how we deliver it will also be a very interesting option.
Desiree?
Yes.
Sexy topic of the year?
Yes.
Where do you think the exercise is going to help?
Do I think it is going to help? I do think it's going to help.
Okay,
but I think it's more of I don't know.
It's a bit of everything.
It is.
Next sexy topic. Desiree, you go first.
I don't know how it's possible, but more about enhanced recovery. In a way. I know you gave me that look like just stared at me.
Everybody do that already?
No, that's the problem.
I've been to a lot of conferences. We're all doing it.
No, they're not. Nobody's doing it.
We're not.
Are we just saying we're doing it?
Yes. No, everybody says they give a carb drink and they may or may not do multimodal pain management and they're doing enhanced recovery.
And we can put a link in the UK, for example, where we thought we'd boxed this off in 2013 or whatever it is. Our Perioperative Quality Improvement Programme, PQIP. Mm-hmm. We'll put the link into the Royal College of Anaesthetists website. The annual report, maybe 2/3 penetration,
And that's in a country that's been doing it for 20 years.
Yeah. What about Simon? You do it all the time?
We do most of it most of the time.
But what don't you do, Simon?
What don't we do? I don't think we're very good at multimodal analgesia. I don't think we're still very epidural-centric where I work. I don't think we've moved on from that very much. We've not really embraced...
Can I ask you a question really quickly? Is that a UK thing, you think?
I think it's regional. I think there are some centres that...
Excuse the pun.
Very good. I think it depends on the centre. We've always had a good pain team. We sort of grew up around colorectal surgery, particularly. We're very epidural heavy. I don't think we've changed particularly with the evidence.
I think it's interesting because in the U.S., and I think the opioid crisis has pushed this for us, is that I feel like multimodal has been a bridge and an entree into enhanced recovery. So I think if people are saying they're doing enhanced recovery, it's usually because they're doing multimodal pain.
Do you think in the US the pendulum has swung the other way? Because I go there, I talk to colleagues, and if you're having your lap right hemi, you get some gabapentin and some ketamine and some lignocaine and some dexmedetomidine. That seems like a lot of polypharmacy.
There definitely is polypharmacy. And one thing that I think the issue with multimodal is, I'm not totally against all that, because I think hitting receptors, all the different receptors in different ways, I think it's a good thing. The one issue that I have is that people don't understand how that affects anesthetists. Anesthesia providers are not following up with their patients postoperatively. So they may be doing polypharmacy, and it may look fantastic in the OR, and it may look great in PACU, but what does that look like on the hours and days later? So that's my issue with it.
What about monomodal? They're not completely monomodal, but we recorded about methadone.
I know what you're talking about.
I don't think we've done just morphine, for example, for a very long time in the UK. We've been multimodal from the point of view of non-steroidals, paracetamol, a little bit of whatever for a long time.
Oh, yes.
But the newer drugs haven't really been embraced, have they, in the UK as much?
Like what?
Lignocaine's becoming more popular now, I think, but certainly ketamine and dexmedetomidine infusions have remained relatively unpopular within this environment.
We did an interview with Evan Koresh from the editor-in-chief of the journal Anesthesiology last year, and that was all about methadone. That was worth a listen.
It was really interesting.
Have you been there yet?
Methadone? No, not at all. I've got no experience with that. I don't know any colleagues who have either. It has some very appealing options.
I think in the US that's going to be something this coming year we're going to hear a lot more about.
Okay, Simon, give us one. We know you've got to get you onto a train soon. Where are you going?
Closed loop. That's what I see happening next.
Okay, tell us a bit more about that.
Automation, unburdening ourselves of things that we don't do very well and handing that responsibility on to computers and to machines. And the two that we have at the moment are fluid management and blood pressure management. Okay,
do we have some examples where that's happening already in medicine that you are experienced with?
But the closed loop, there's lots, well, not lots published, but a lot of case studies coming out, mostly from Alexander Euston and his team. But they've done closed loop anesthesia, closed loop vasopressor management, and closed loop fluid management, all in the same patients.
So this would be the fact that you've decided you want to keep the blood pressure at a particular level with an infusion of a drug, a vasoactive drug, and the computer adjusts the amount of drug you're giving to keep the blood pressure at the level that you've decided. So Absolutely. The closed loop is not taking you out of the decision making.
No, it's the same analogy. It's the autopilot. The pilot sets the speed, the altitude, and where you're going. The computer just keeps you there better than he can. They can fly that plane better than a pilot.
Yeah.
Mike Grocott, go for it.
What do you think?
I'm with you on prehab. We had a lot last year, but I think there's going to be a lot more this year.
Yep.
I'm going to obviously share my personal biases. I think the oxygen therapy story will continue to grow. I think there's going to be both publications and I suspect new studies kicking off.
Okay.
I think in the perioperative space, shared decision making and work around that, and I think particularly. So Rupert Pearce's Osiris grant in the UK, which is a big programme grant working alongside the Centre for Perioperative Care. I think there could be quite a lot there. I think they're going to be reaching out to people to get input on that.
Oh, that's exciting.
I guess more away from the clinical domain, I think, and this is partly UK perspective, kind of first week back in the new year, the things I've been drawn into. I think the whole notion of acute care, looking at the commonalities between the acute, typically craft specialties, say surgery, anaesthesia, critical care, trauma, injuries, emergencies, all that kind of stuff. I think that will become more important as we try and stack ourselves up against the big, well-funded research specialties. And I suspect... Are we allowed to mention Brexit? You said we weren't allowed to mention Brexit.
Well, okay.
Ish.
So, I suspect that given that it looks at it like it's going to happen, we will move on to more domestic policy issues, and the current government here seems to have pinned their colours to the NHS mast.
Yes.
And given the advisors around the elected officials, I think we might see some pretty radical stuff going on.
Well, so for the final one, we hope that will happen.
Which I think is good. I think we need, the usual story: scarce resources, ever increasing demand. I think there'll be lots of interesting ideas around who does what, sort of role displacement.
So we're going to write that one down and pin that on the board, and we're going to come back next year and we're going to discuss that in detail. And hopefully it'll be a champagne moment.
Good. Hopefully not a sham moment.
We hope we're not rubbing your nose in it. Which we wouldn't do, but let's pray for that one. That would be great. Noel, how are you, buddy?
I'm great, thank you. What a pleasure to be here.
You do not look at all like a man who's just come off the red eye from
No, you don't. I'm
North
impressed.
Carolina.
Thank you for lying.
It's a great thing about radio.
I have a good radio face.
Podcasting. We're a podcasting company.
So, Sol, we have been doing a little teaser series as a New Year's special. Hot areas for 2020. Top 3. Now, we can give you a little bit of the list so far. We've had, for example, prehabilitation, which I think is currently coming out as number 1.
Yeah.
We've had a little bit... Desiree Chappell still thinks enhanced recovery is in play. We kind of think, oh, come on.
It's an oldie but goodie. That's what I keep saying.
We've had artificial intelligence and closed loops.
I think those are good. I still think the opioid endemic and how we contribute to its exacerbation or mitigation with respect to our behaviors in the perioperative space is going to remain on the top list of topics appropriately. I also think just care coordination in the perioperative medicine space in general. Okay. I think we are becoming more inclined to appreciate the transitions of care into that sphere of perioperative care and out of perioperative care. And I think how we coordinate that care is critically important, and I think that will be discussed with great passion and appropriate credibility and importance for the next year.
So, one more.
Yeah. I would say to be able to deliver the care to the populations that heretofore didn't know they needed it or were unable to get it.
To hard to reach populations.
So I think it's a policy and a delivery kind of sense. I'm not trying to be political, but I think the concept of people needing surgery need surgery, but you shouldn't have surgery until you're ready for surgery, and not fully embracing and appreciating what it means to be ready for surgery is a topic that I think is very important and will raise to the level of interest.
Do you think it's harder to reach larger population of people where you work that don't quite get the opportunity to understand that yet?
I think we're still, particularly in the States, in a transition of understanding what the external pressures are on us to evolve to a care delivery system. And so, again, perioperative medicine is population health, and what we do to enhance the health of the population is meaningful about how we engage these people in the perioperative space once they're declared surgical.
Sol, thank you very much indeed for adding to the list.
An interesting trio of opinions there. You're listening to TopMedTalk. My name's Nick Margerrison, and we're having a look at some of the predictions for 2020 that some of our contributors have given us over the last month or so. Andrew Klein now, cardiothoracic anaesthetist at Royal Papworth Hospital in Cambridge and editor-in-chief of Anesthesia.
Hot topics for 2020.
Well, everybody at this conference, and there's over 1,000 people here today. It's incredible, the vibrancy here. Everybody's asking about environmental impact.
Yeah.
Environmental impact of anesthesia, both of the plastics we use, the drugs we use, the vapors we use. So I'm just looking around me. All the stands are looking at environmental impact. And there's a lot of papers coming out on the environmental impact of what we do as anesthesiologists, as surgeons, as physicians. And not just physicians, as the whole team. And there's no doubt that our contribution to the impact of our healthcare as a whole is huge.
Sharp rising ball then. I get my anaesthesia delivered at home in a plastic bag. Okay.
No, you don't.
I do.
No, you don't.
I haven't opted out.
That's because you haven't noticed that the February edition of the journal is coming in a potato wrap.
All right, in a potato wrap.
A bio wrap.
But I still
We've changed. We've stopped using plastic, so your February edition is in a bio wrap.
And it's all recyclable.
It's all recyclable, so it goes in your green bin. No plastic. No plastic. And our paper is plastic free too, and it's all recyclable. So the entire journal. So you will find that some other journals that are blue in colour come in a plastic wrap, and the orange one comes in a bio wrap.
When's it going to be e-only?
Oh wow, that is a whole other podcast. Don't go there. It's a big debate. But
okay, what else? What other hot topics?
So environmental, I said. So you said opioids, the opioid crisis, opioid free. We've got a lot of papers about people looking to refine their techniques not to give opioids, and that's not just in surgery, but it's afterwards. So the patients don't, if they have a good block, they don't need an opioid. They don't need it at the beginning and they don't need it afterwards. So a lot of people are looking at their techniques. There's a lot of new drugs out there, a lot of new techniques. So there's a lot of papers coming on blocks, on opioid-free techniques, on opioid avoidance techniques. So I agree with you on that. So
any other hot topic? One last one.
Anemia.
That's
iron.
I said anemia too.
Don't forget to check out the show notes for more details on these conversations and for the fuller versions, www.topmedtalk.com. Now, though, let's have a listen to Tom Woodcock, author and independent consultant in patient safety, medical law and ethics. He gave us some of his thoughts about what to expect in 2020. Have a listen.
Top hot topics for 2020. What are your top three? Try to avoid politics and Brexit.
I will totally avoid politics and Brexit, and I'll go back to something else that I did when I was a young man in the 1980s, and that was open loop control of blood pressure.
Oh, cool. Excellent.
And that came up, as I hear, under closed loop. Now, closed loop is dangerous. Yeah. I think for a long time it's going to have to be open loop, but that can be done with very elementary technology.
So more akin to fly-by-wire?
Yeah, you can look up some of my papers. We were taking patients down to a low blood pressure and we were keeping them at a low blood pressure with incredible precision. One of the unpublished studies we did was to challenge any anaesthetist who wanted to try to beat the computer to keep the blood pressure as stable as the machine was keeping it, and no one came close.
So we were talking yesterday, because we're going to put this clip in, that the 13 Minutes to the Moon podcast last year, I don't know if you heard it, the 50th anniversary of the Apollo landing. In chapter 5 at about minute 40, they start to discuss the fact that they recognise the fact that humans were not capable of landing something precisely on the moon. Yes. And it's all that period they switched over to the so-called fly-by-wire.
Yes.
In other words, they were making the decisions, but they couldn't do it with the precision to land it safely. And that's open loop, is it?
Humans are not capable of maintaining the blood pressure at the level they would like to maintain it without the help of technology.
And that's why
it's doable. We were doing this on BBC Micro. You remember that kind of technology? Yeah. The same sort of thing that they landed on the moon with.
Yes.
It doesn't take great computing power, and it's always baffled me why we are not taking that forward, because increasingly we're getting the clinical data that letting the blood pressure go too low, even for a short period of time, is incredibly dangerous, and the solution is there at your hands if you will only look to take it. So come on, clinicians, pull a finger out. And number 2 is steroids. And I think that steroid physiology in patients in perioperative care, I think that needs some looking into. You do have some top people who have a top-level understanding of corticosteroid physiology in this country. Bring them to the fore, and let's start doing some investigations along those ways. There are still people dying effectively of Addison's disease after they've had surgery. That is a fact. Yes. We might not like to hear it, but it's true. And we need to take that warning on board, and we need to be working to better, just as we're working to better care for diabetics, we need to be working for better care for people on steroids. And there are a lot of people on steroids. I am talking about inhaled steroids, not just prednisolone tablets.
Number 3?
Fluid physiology.
Boom. and the lymphatics.
And lymphology. I buy into lymphology. Endotheliology.
There you go.
Wow.
There we go.
Time now for our penultimate contributor. It's Henrik Kehlet, gastrointestinal surgeon and former professor of surgery at Copenhagen University, now a professor of perioperative therapy and head of section of surgical pathophysiology in Copenhagen. Henrik is a very popular contributor here on TopMedTalk, and we highly recommend you have a listen to both the original interview from which this clip is taken and also his original appearance on TopMedTalk. Both of them available in the show notes. Let's have a listen to the conversation that Henrik had when he was asked about his hot topics for 2020.
Well, Monty, we have been having this discussion the last couple days about predictions for 2020.
Yeah.
And what are some of the hot topics. So I've gotten a lot of flack for this over the last couple days. That I say it's an oldie but goodie. I said, but as you say, we're not actually all doing it.
No.
And doing it the right way.
No. I'm not against prehabilitation, of course not. But I think we have to solve the post-op problem first.
Yes. Yeah.
Okay.
We have to solve it because patients still get sick. They are fatigued. They have a risk of complications.
Yes.
Mm-hmm. And we have to go back to the pathophysiology of recovery. And then we go down to this inflammation, the inflammatory responses, the old-fashioned hormonal responses. Mm-hmm. It's not important anymore. We don't have negative nitrogen balance as we had many years ago. But the inflammatory response.
That's the key. That's the unifying component of it.
Exactly.
Mm. So the lecture that you gave today is kind of in that a little bit. So you can tell us about your lecture this morning?
Yeah, the background for it is really asking the question, why is the patient in the hospital? About 3-4 years ago, there was a fascinating study from Stanford by Bryce Godelier and co-workers. And they analyzed in detail immunological signatures after hip replacement. And the outcome were time to achieve mild pain, fatigue, and hip function. And they showed a fantastic correlation about the duration of recovery versus these inflammatory changes. So we took samples from our RCT, sent it to them with plus minus high dose steroids. And it's hopefully in press now in a very famous journal, showing in detail for the first time ever what happens with these immunological changes. And it lasted for up to 48 hours. And I think all this is fascinating. I reviewed the literature from elective surgery with high-dose steroids. A lot of questions, but it's not a safety issue. That is for sure. Efficacy is fantastic. Fantastic. I mean, it doesn't cost anything. It is simple. It is effective. It is safe. What more could you ask for? And you have a fantastic start of your enhanced recovery program regarding fatigue, pain, etc. across procedures.
Monty, you have any other questions?
I would just get from the steroids.
That's what I was heading back
tomorrow.
to.
Okay,
yeah.
well, I was going to say, what can we do tomorrow?
That's what I was just going to say. So do we all go back and we start using steroids on every patient?
As a clinical researcher, you can never force me to say so. You can never force me. I will say it's...
I need an answer.
Yeah, the answer is, it is so far so fascinating.
Yeah.
But there are still many questions. There are procedure-specific dosing questions. Mm-hmm. There is a question about repeat dosing.
Mm.
Well, sorry, Monty.
Is there any type of surgery at the moment where you could say with confidence that you think we should be giving a particular dose of best guess steroid at the moment that's higher than traditionally given? When it's still not quite there?
I think hip and knee, definitely.
Mm-hmm.
Definitely. About 25 milligram of Dex at this time.
Right. Mm-hmm. That may go to a different place, but at the moment about 25.
Yeah.
Thank you.
Yeah.
And one-off dose?
Yes.
Okay.
Because we need more data on repeat dosing.
So I'm going to add two proposed topics to our top hot topics for 2020, and that's steroids
Yes.
And I'm going to add the pathophysiology of recovery. We talked about this before, Henrik, and I know Sol's working on a series for perioperative medicine and a series of organ by organ. We have to go back to the pathophysiology. We have to go back to studies that explore the pathophysiology.
Exactly.
It's an honourable place to be. Good PhDs, discovery. And we've kind of gone to the mega trial and we've lost sight of the pathophysiology.
Exactly.
Yeah.
And we have to move away from guidelines, I think.
Yeah.
Research, pathophysiology. That's the way forward.
And now for our final contributor, Matt Wiles, consultant anaesthetist and senior clinical lecturer at Sheffield Teaching Hospitals NHS Trust and the University of Sheffield. Let's have a listen to this. I'll give you some words at the end.
I just want to ask you, I kind of teed you up a little bit this earlier, but we've been asking everyone about hot topics for 2020. Now, so far, I'm not going to give you the whole list, but we've had things like, I'm not going to ask you if you believe in these or don't believe in them, but if they're on your list, you can pick them out. Prehabilitation, oxygen levels like oxygen toxicity, whether we're giving out too many opiates, artificial intelligence and closed loops. Do you think any of those would be on your list? We're not looking for the ones you don't like. Is any of them on your list? And do you have any to add?
I think hyperoxia, particularly to neuroanaesthetists, we've seen the association with hyperoxia and worsening mortality and stroke. And whether that's correlation or causation, we don't know. I think at a personal level, it's a drug. As anaesthetists, we're very bad at titrating. We sort of try to individualise care a lot, but a lot of people just run all the patients on 50% for as long as it takes because that's easy, and don't necessarily think of it as a drug that will have benefits, but also possibly complications.
Any of those other ones on your list? So oxygen's on the list, I'm taking. Any of the others? And if not, give us two others.
I still do some preoperative assessments, so rehabilitation, surgery schools, fitness for surgery. No doubt it's a benefit in terms of duration of stay, patient-centred outcomes, patient experience is much better. What I'd add, following on from conversations about e-journals, would be sustainability in healthcare and the environmental impact of what we do as clinicians, the choices we make, the drugs we use. The NHS within the UK uses an awful lot of carbon. Our carbon footprint is huge.
Yes.
And even in terms of education, I mean, perhaps what we're doing now and sharing thoughts throughout the world rather than flying over there may well become a model that becomes ever more common.
I'm sure you'll agree, a fascinating programme here on TopMedTalk today. We'd love to hear your feedback. What do you think will be the big talking points on the perioperative calendar in 2020? Send us an email, nick@topmedtalk.com. That's nick@topmedtalk.com. We love reading your feedback and maybe we'll include it in a future programme. Thanks for downloading Top Med Talk. Don't forget to subscribe and of course check out the website topmedtalk.com.